Hey everybody, I'm just at my home office here, which has evidently become the landing place for my kids' artwork. So I've got some nice decorations here around me. Just ran into a case study that I thought would would be interesting to just kind of go through quickly because it sort of highlights a topic for us that has a few complex wrinkles to it. I just thought it made for a nice example of a few talking points that might be good to understand, particularly if you're using Dutch to monitor hormone replacement therapy, and in this case, oral progesterone. So we're looking at a woman on the other side of menopause. She's got a lot of menopause-related symptoms. She's sleeping really poorly. She's got anxiety. At the point of her first test, she's only taken melatonin. So we look at her first results. You can see, remember for us, the premenopausal range is up here, and then the postmenopausal range is that purple band. So pretty severely low for estrogen and severely low for progesterone, even below the postmenopausal range. Now remember, that's an adrenal hormone if your ovaries aren't kicking in, right? So then if that's the case, you're definitely going to want to look at the cortisol and make sure that the adrenals are functioning properly. If the progesterone is super low, in this case, her cortisol is actually fine. So she just happens to make not very much progesterone, even for a postmenopausal woman. Now, here's a nuance that we'll get into with her follow-up test that is somewhat interesting and feeds into sort of the interpretation of oral progesterone, specifically with the urine test. So for progesterone, we're monitoring these two metabolites, right? It's beta-pregnenolone and alpha-pregnenolone. Now, what you'll notice is beta-pregnenolone is in the postmenopausal range, and alpha-pregnenolone is well below it. Now, it's a little bit subtle here, but what I'm going to suggest is that she's got a preference towards pushing it towards beta. Now, when she's not on therapy, that's not very interesting. They both just tell a progesterone story. We take an aggregate of the two, look at the correlation with serum progesterone, and that's where we come up with our serum equivalent. But the story here is just she has almost no progesterone, right? Then she gets treatment, okay? Continue the melatonin. She's put on an estradiol cream, and then oral progesterone, okay? So if we look at her requisition, again, progesterone, 1 is oral, 3 is transdermal for estrogen. That says half a gram. That's not half a milligram. That's probably half a milliliter of whatever dose it is. So oftentimes we don't actually know the dose because they'll write something like that. But what you can see from her follow-up is if the estrogen's way up here, the estradiol, I'm guessing that dose was somewhere north of a milligram potentially. Usually takes that much to get women up that high. We could discuss that. That's not really the point of this particular video. So suffice to say that I think this range down in here makes maybe a little bit more sense, but it depends on what you're trying to achieve. So I don't know what this particular situation is. The progesterone serum equivalent we list here is not a concept that is legitimate when they're on oral progesterone. There'd be a note right there on the report that says, that concept is only for people not taking hormones. When someone's on oral progesterone, we want to look at the metabolites. And what you'll notice for her, and this was what I thought was just kind of an interesting observation as it relates to the impact of oral progesterone, is she is pushing that progesterone orally down the 5-alpha pathway. You say, okay, well, what's the significance of that? Well, if you look at this, her androgens, remember her baseline test was pushing down the beta pathway, okay? So you're most familiar with this concept when it comes to testosterone and androgens, right? If they head down the alpha pathway, they get more androgenic, like testosterone turns into DHT, it's 3 times as potent. This is the best place to evaluate this in a female, is to say, which way does androstenedione go? And you can see here, not talking about the number, but the relative number, that 620 is a little bit higher than 606 when we're talking about the beta metabolite relative to its reference range compared to the alpha. So we would call her a beta metabolizer. Now, if you look on page 2 of her report, you'll also see androstenediol. These are those testosterone metabolites. The alpha is below range, so same enzymes, 5-alpha, 5-beta reductase, and the beta is a high end of range. So what's that? More beta preference, right? So beta, if you look at cortisol, same thing, beta, right? The beta tetrahydrocortisol is high end of range, whereas the alpha is within range. So there's a bit of a preference towards the beta, and we saw that in her progesterone as well before therapy. But then after therapy, it's the only thing that's pushing down the alpha pathway. So you might think, well, that seems kind of inconsistent, right? But here's what we know about progesterone. Normally, it's metabolized alpha versus beta by what? The liver, right? Which is also metabolizing the androgens and all. And so you normally get a pretty good harmony there. But when you start taking it orally, here's an excerpt from an old paper that sort of describes this for us, is that oral progesterone is metabolized first by the intestinal wall and the liver. Oh, here it is. So first step is intestinal bacteria, which sends it down the beta pathway, and then the intestinal wall sends it down the alpha pathway. So before it hits the liver, it hits the gut. And the point is that depending on the configuration of your gut, the bacteria in there, the intestinal wall, send it preferentially down different pathways. So when you take it orally, your breakdown of progesterone is potentially going to be different than what it is in the absence of oral progesterone. And that impacts its clinical effect, because we know that oral progesterone works by way of its metabolites in terms of its help with sleep and things like that, right? Allopregnanolone works that way. Just to finish out something they said here, they just point out that vaginal the vaginal space doesn't have these enzymes present. And so when you take progesterone vaginally, that's why you don't get that allopregnanolone, which is why it's really helpful as it relates to the endometrium, but it doesn't tend to help with sleep, right? Because you need it going through the gut to get a lot of those active metabolites. There's the reference down there on the right. So progesterone is going, this is the beta pathway here, and this is the alpha pathway here. And so what you're creating are twins, right? Cousins, whatever you want to call them. There's the alpha version and the beta version of each of these metabolites until it gets down into the urine, and then we measure, go back here for a second. So what we're measuring is what we call alpha pregnenolone, is in urine actually the alpha pregnenolone glucuronide, and then the beta pregnenolone glucuronide, which some people just call pregnenolone glucuronide. That's the typical marker in urine. So if you look at on our panel, here are just two sets of examples of someone on oral progesterone. That beta metabolite is what urine testing usually monitored historically. So you do a 24-hour urine, that's typically the only marker you would get. And they weren't looking at the alpha, which you can see from these two examples can be really, really different depending on, again, what's going on in the gut. So we want to look at both, especially since those alpha metabolites are of particular interest. So again, these two examples here, really, really different of what's going on in the gut, even though the progesterone exposure in terms of supplementation is the same. Now, you may or may not be familiar with John Weave's work. This is all in vitro, but it's pretty interesting. So he took those alpha metabolites of progesterone, the whole family of them, and then he tested them to look at what the impact was on breast cancer cells. And what you see here flaring up, if you will, are those alpha metabolites. So they have a bit of a proliferative effect. So we've always said, this has never been really chased down in terms of research, in terms of actually monitoring ratios of these things and looking at, people on therapy and breast cancer outcomes. We know as a class of people, the people taking oral progesterone don't have higher risk of breast cancer, but is there a more nuanced story with the metabolites? That's really never been examined in any great detail. But John Weave's work is interesting in that it implies or shows that, at least in vitro, the alpha metabolites may have a proliferative effect, and so that might be something to consider. Now, when we look at this woman and her symptoms, you can see this is her baseline. So she's having a lot of trouble staying asleep. She's anxious. She lists anxiety and sleep. When she tested again on the oral progesterone, she's doing a little bit better with anxiety and a little bit better in terms of falling asleep, but still just not able to sustain sleep. Now, if we look at her results again, when it comes to her metabolites, again, we know she's making lots of that sleep-friendly metabolite in terms of the alpha family of metabolites. And then when you ask yourself, okay, she's not sleeping well, she's still anxious. So shall we push further? Shall we increase the dose to see if we can get that? And what we would argue is in this type of a case, she's already making a lot of those pretty active metabolites that have that impact, that maybe you want to pause on any consideration of increasing the dose and go look at other things that might impact her sleep, that might impact her anxiety. For example, that follow-up test for cortisol was even higher. So maybe there's some impact there, and maybe some other testing that needs to be done. But as it relates to evaluating this woman, in particular the oral progesterone, that's something we want to look at. It's just, where is she pushing that progesterone? If she's pushing down that alpha pathway, then we're going to assume that she's making a healthy dose of allopregnanolone and those more active metabolites. And we want to take that into consideration as we evaluate the overall picture for this patient. So I just thought that was an interesting case in terms of the overall pattern and the way the oral progesterone actually projects a different pattern than the rest of her metabolism, again, because of what's going on in the gut. And there's a lot of research left to be done to really fine tune that picture of, then can you alter what's going on in the gut? And as you fix someone's gut that may be problematic, is there going to be a subsequent change in how they handle progesterone and then the clinical impact of the same dose? We don't know the answer to all those things. So there's some conjecture there, but it's definitely worth thinking about those things as you're listening to your patient, looking at the symptoms, and considering, future treatment and treatment changes, and just trying to figure out what's best for that individual patient. So I hope that's been helpful. Again, I thought that case was kind of interesting, so I just wanted to share that kind of informally with you. If you have any questions, feel free to reach back out to me, and be happy to continue the conversation.